My name is Diana G. Rajarsingh. I'm an assistant professor of strategic management here at Rice University, and I am moderating the next session, which is Global Case Studies for Pediatric Care. We are going to hear from two speakers whose work exemplifies how global collaboration strengthens pediatric and newborn health systems. So our first speaker is Dr. Joseph Lubega. He is the director of the Global Hematology Oncology Pediatric Excellence, or HOPE program at Texas Children's, and is an associate professor of pediatrics, pediatric hematology and oncology at Baylor College of Medicine. He also led the establishment of the first accredited pediatric hematology oncology clinical fellowships in East Africa and has spearheaded the development of the continental strategy for sickle cell disease with the African CDC. Next, and after that presentation, we will hear from Dr. Natasha Rhoda, and she is a senior neonatology advisor with the NEST 360 Technical Advisory Team and head of the clinical unit at Mowbray Maternity Hospital at the University of Cape Town, formerly the Neonatal Care Improvement Advisor to South Africa's National Development of Health. She brings deep experience improving newborn care systems across sub-Saharan Africa.
I'm really glad to be here among colleagues who are passionate about health disparities and global health. And what I'll share with you today is the experience of the Texas Children's Global Hematology and Oncology Pediatric Excellence Program. And I know for many of you here, you don't need convincing why it's really important to address health disparities. But I want to give you a clear flavor, just in case we forget, why these disparities exist. And so much is said about disparities in the US, as the prior speaker mentioned. But what I want to appreciate in the pictures I'm going to show you is several things, that everywhere you go in the world, there are really very, very wide disparities in access to resources. And these are socioeconomic geopolitical problems. Two, I want you to appreciate that the majority of the people in the world live in the poorest parts of any country, any city you go to in the world. Three, for those of us who are really into maternal and child health, the majority of mothers and children live in those poorest communities. So this is Mumbai, India. Again, you can definitely see way more houses down in the forefront than the background. Okay, this is Guatemala City. You have a few people patched up on top of a hill, and then a crowd down on the slopes. And those are people who are literally living on the edge sometimes, okay? This is Nairobi, Kenya. Again, you see more people on the left than on the right. Kenya actually, on the forefront, has one of the biggest slums in the world. Okay, so many people living in those slums. If you zoom into those slums, what you see is children everywhere. I've been to some of those places, and that picture, I can tell, is not a fluke. You find those places are full of children. Okay, this is Johannesburg, and this is Cape Town. As a matter of fact, South Africa is the country in the world with the widest socioeconomic disparities in the world. Thank you. So, and these are the children that live in those places. So, and those children need care. And many of my colleagues tell me, hey, so Joseph, those of you who are doing global health, it sounds like you're trying to solve poverty problems with medical interventions. And the answer is yes. It's important to deliver medical care to these communities because one of the biggest reasons that these communities are really not developing is because of the burden of diseases. Two is if we accept that these socioeconomic problems are not going to be easily solved in our lifetime, then we have to find another way of delivering care, accepting that these socioeconomic disparities are going to persist. And for many years, global health was the work of charitable missionaries. HIV, 1990s, early 2000s, with focus on infectious diseases, made it a field where people had to reinvent how do you deliver particularly HIV care, TB care in these communities. And now it has expanded to all areas of medicine, and it's a methodic academic discipline. The pharmaceutical business are interested in it because that's the bulk of the markets now, as more and more people live in poor communities. And it has been recognized as a really effective tool of global health, global diplomacy. So for us at Texas Children's, as one of the largest centers for pediatric cancer and blood disease care in the US, this is what got us involved in global health. So in the US, there are around 15,000 children that develop cancer every year, and 80% of them survive. In Africa, around 100,000 children develop cancer every year, and 90% of them die. And they don't die because we don't know how to cure childhood cancer. They die because we can't get care to them. There are around 1,700 newborns with sickle cell disease annually in the US. 90% of them survive to really a productive adulthood. In Africa, around 300,000 babies are born with sickle cell disease every year, and 50% of them won't live to their 5th birthday. And the interventions to control sickle cell disease are really basic health interventions. So what we do is, together with the ministries of health in these countries and so many partners, we came up with a simple formula. We train pediatricians in these countries to become pediatric hematologists, oncologists, specialists. But the key thing is we don't train individuals, we train teams. So when those pediatricians qualify, whichever hospital they go to, we follow them and train a team of nurses, pharmacists, pathologists, whoever they need to do their work. We support them with basic medical supplies and diagnostics to get started. And once they start delivering good care, the governments see the value and the savings from improved care delivery. We keep nudging these governments to really step up the game and start paying for those services. So this is what we've achieved so far. We've trained 36 specialists. These are very formal programs similar to what a US pediatrician will go through in terms of training. And as you see on that picture, on that slide, they are from Botswana, Malawi, Tanzania, Congo, Nigeria, Uganda, South Sudan. And around them, we've trained over 200 pediatric cancer nurses. So these teams we've trained now support 12 pediatric cancer centers in 6 countries. They see around 2,500 children with cancer a year. Many of these countries, before we started this program, no child ever received cancer care. And they see around 10,000 children, among them with sickle cell disease. So just to show you the impact of this, on diagnosis of cancers in children. So that pie chart shows you the typical distribution of childhood cancers in the US. Leukemia, brain tumors, and lymphoma constitute around 2/3 of cancers in children. Before we started this work in Malawi, this is the picture they were seeing. Everything pretty much was called lymphoma or soft tissue cancer. So you can imagine how many children, even for the little care that Malawi was able to deliver, how many children actually got the wrong treatment. So even that resource was wasted, let alone harming the children. And this is what they're seeing now. So they are seeing leukemia, they're starting to see less lymphoma, they're still trying to see brain tumors, which we assume is because of lack of access to brain scans. But in Uganda, where the team has been more comprehensive and more work is done, you see the pictures that really look like the cancers you see in the US. They are still struggling to diagnose brain tumors there. And again, we assume it's because of lack of access to MRI scans and brain surgeons. In terms of outcomes, excuse me. So in terms of outcomes, these 6 cancers represent the 6 cancers that are most curable in children, and WHO has designated as low middle-income countries should cure. And as you can see in the US, 85% to 95% of those children are cured. And in the centers we support, they are really starting to cure many of those children, with the exception of, again, brain tumors where they are still struggling. So that's where we are now, but statistics obviously never do justice to work like this. And I just want you to watch this video, it's 90 seconds, so you get a sense of what this kind of work means for family and for a child in these settings.
I was weak. He was not able to walk. Then I was not strong enough to stand. My life was in trouble. I felt that I was going to die.
I was very afraid. Even when I talk about Natasha, I always feel like crying because I knew it is going to leave the world.
She was brought in by her grandfather with the stories that most of our patients present with, been to several local hospitals, sick 4 months. She was diagnosed with acute myeloid leukemia. Most of the caregivers are female, mothers, grandmothers, but this was different. The vision of the Global Hope program is to ensure that children diagnosed with cancer in sub-Saharan Africa receive the most effective therapies available and ultimately experience treatment outcomes similar to those in resource-rich settings. Having Natasha treated in a low-resource setting, being cancer-free for 3 years is a reason to celebrate.
So, there are thousands of Natashas now in many countries in Africa because of this work. But one of the things really, to me, I want to stress that maybe not be obvious in that video, is that there isn't a single Texas children's doctor or nurse. This is work that was done by people out there that we've trained, and that's really is capacity building. So I want to shift gears, talk about sickle cell disease, which is a major public health problem in Africa. Those of you who may not know, sickle cell disease is a genetic disease. In fact, it was the first disease even in the world to be determined to be caused by a genetic mutation. At Rush Medical School in Chicago, that was around 1910. And to date, most children with sickle cell disease in the world die. And they die because most of them are in sub-Saharan Africa, India, and Brazil. The interventions to control sickle cell disease are really simple, right? You can screen a child for sickle cell disease for $1, prevent them from getting infections through vaccinations. If you're in malaria endemic parts of the world, malaria prevention, penicillin, old penicillin, 10 cents a pill. And then reducing sickling with this drug called hydroxyurea, a generic, which costs around 20 cents a day. And these interventions are what are responsible for most people with sickle cell disease in the US living to adulthood. Very simple interventions. So we decided that we can do something about this. The colleagues we trained in Africa take care of around 10,000 children with sickle cell disease a year. And they realized, hey, you don't really need a hematologist to prescribe penicillin, to screen a child, to give hydroxyurea. So they decided they want every health worker on the continent that touches a child to be able to deliver these interventions. And so we started this partnership with the Africa CDC, which is the health agency of the African Union, with a goal that we get presidents, governments, ministers of health, communities, everyone, to commit and be involved in sickle cell control. Train primary healthcare workers to deliver those interventions, work with pharmaceuticals to expand access to medicines, and integrate data tracking in the existing data systems. This work has been going for just over a year now in terms of rolling out the work, and it's really already shown very early signs of success. We've rolled out the program in Uganda to start with, and as you can see on this graph, they are now screening over 1,000 children in several districts every month. and they're actually picking up the exact incidence of sickle cell disease you will expect in these populations. Typically 1.5 to 2% of newborns are expected to have sickle cell disease in sub-Saharan Africa. One of the biggest challenges when people have done screening, and I can tell you this is a challenge even in the US, is when you screen a child, how do you get them into care? And with shifting in Africa from doing centralized lab screening to point of care, actually they've been able to now 99% of the kids are linked into care simply because you do the test on the spot where the baby is born or at a vaccination visit. When they find the child has sickle cell disease, they immediately move them into care, which is the opposite of what we do in the US, where you get a sample collected, a heel stick at birth, and you wait for at least a month to get the results, and sometimes tracking those newborns can be challenging. 99% of the kids now on hydroxyurea, meaning their disease actually is controlled and they're less likely to get complications of sickle cell disease. So this is my last slide, just to share with you very briefly, what is it that we've really learned in these experiences? There are three things that we all talk about a lot in global health that I think can be buzzwords, but we're often not clear what exactly does it mean. And that's capacity building. You're always going to be asked about scalability and sustaining what you're doing. And I would say from our lessons, definitely building capacity and building scalable, sustainable programs starts with teaching and mentoring. You have to do it. And I would say it's probably the easiest part, but if you just do that, you won't get anywhere, right? Many have trained people and those people disappear, brain drain. One of the things I think that has made our program successful is we could have taken African pediatricians, brought them to Houston to train them. That's how I ended up living in Houston. I call myself a Houstonian. I came with the idea, I'll come here, train, and then go back. You never go back. So much moves on, including the fact that you can't go and start practicing by yourself. So once you train people and mentor them, you need to build systems and structures around them. And that really comes down to, in terms of medical interventions, making sure they have the drugs, the supplies they need, that you build multidisciplinary teams, don't just train the doctors, but the nurses, the diagnosticians. Building care pathway processes, and sometimes, which we try to avoid, and I know many people invest so much money, facilities, but sometimes we need to renovate and improve facilities so that they can provide the care they need to do. And then above that, really to make things stick, you need to influence institutional and engage in political advocacy. And so we spend a lot of time in boardrooms with ministers of health, with pharmaceutical companies, but also with communities, so that these people you've trained, these structures and processes you've built, now are anchored in an organizational structure that can support them and finance it perpetually. And when it comes to health, especially in these settings, policy is really the holy grail, okay? Because without whatever you do, without moving into becoming policy of the country, you'll never get it funded. You can have all the beautiful designs you want, you never get it funded. So really, no one can guarantee, and this is something that people keep talking about, when talk about sustainability, there's this impression that, guarantee that you will fund this forever and ever indefinitely. No one can guarantee funding forever. Even governments budget year by year, right? But if you can stick a program, an intervention into national policy, you've guaranteed that will always be looked at. Thank you.
So thank you for that. So I see by name, Natasha, and by synergies that I see the two speakers before me, I was really meant to be sitting here today. Thanks, Joseph, for that look into cancer. Another one of those burdens that our continent carries quite heavily. So when asked to do this talk, It's really a culmination. I sit here after working in South Africa and sub-Saharan Africa for the last 30 years. And I think the talk, I wanted to bring some hope, and I'm hoping that you'll share that hope with me at the end of this talk. And so I've named it Shifting Our Paradigm of Newborn Care in Africa. So thank you for the opportunity to Rice University. So briefly, and for the audience, I know it's going to be quite important for us to give you some global perspective. And for those of you who don't know about NES 360, which started as a year at Rice University, I'll give you some insights. Talk about the pillars, which I see as innovation pillars, and there are 3 of them. But I'll go through that quite quickly, because I really want to get to the nub of it, which is how do we shift the paradigm, and what are the insights that we have learned as the university, as part of the program, and I guess to a certain extent also, if you allow me, what are my insights that I've seen having worked in this milieu for the last 2 to 3 decades. So the students among you, I don't know, you look a bit younger, but certainly when I was a student, the first thing I heard about newborns was when I was an undergrad in the late 1980s, so you can guess my age as well. And then what stuck with me was this GOBI FFF, and I still remember the 3 Fs, female, food, and family planning. And so on the top line, you can see the global initiatives. And they all spoke about, firstly, the wording change. First the child, then the baby, then the mother. So a decade after GOBI FF, and you see things don't happen that quickly, even on the global scale. People started talking at the World Summit for Children about highlighting how many kids are dying, and specifically in low and middle income countries. It started the seed for the Millennium Development Goals, of which there were 8, and you can see on the side there were 8 of them, if you remember. And the 4th one was really about the under 5 mortality, reducing that by 2/3. Bearing in mind that things haven't changed much because babies actually constitute almost half of that under 5 mortality. And sadly, as most of you would know, and certainly Joseph and I know, in Africa, very few of the countries reached MDG 4 in particular. The few that did were small countries and also island countries. And so SDG was a broader scope, 17 goals, and SDG 3.2 specifically started speaking about preventable deaths. And at the bottom is the evidence, mostly coming through the Lancet series, where they first spoke about saving babies, then saving children, and then saving mothers. And the names changed. Every newborn action plan started talking about preventing those preventable deaths, as you have in maternal. So by 2016, when the Lancet maternal series came out, the wording was now Eweni. And I don't know if anybody remembers what Eweni was, but it's every woman, every newborn, everywhere. And a few years later, that's where you can see the nest actually started. Our phase 1 started in 2019 for 5 years, and we're now in our 2nd year of our 2nd phase, and the end is nigh, 3 years hence, at the end of 2028. So what does that mean for my continent, for Africa, and specifically for sub-Saharan Africa? Well, you can see this graph shows you that unfortunately, it's going to take almost a century for sub-Saharan Africa to reach the neonatal mortality rate that you enjoy in high-income countries, around about 2 to 4, an average of 3. And that's really an indictment upon ourselves, because it will take 3 times longer than it took for the high-income countries, despite all the new interventions. There is some good news, and this is March of this year, where we could see that there is a decline in the under 5 mortality. But unfortunately, there's a static amount within Africa. Still 1.1 million neonatal deaths per year, and it's been the same for 3 decades. Let that just sink in. For 3 decades, there's been no change really. And unfortunately, the rate at which babies need to be saved is just increasing, close now to the ARR annual reduction rate for mortality, close to 10. And so it's no wonder that for March 2026, the slogan now is faster together, and it's needed more now than ever before, with the theme of healthy beginnings and hopeful futures. We do know, as you've also heard this morning by the first speaker, that the care around birth is really where we can win the most. It's a triple return on investment. This was the 2014 work, which showed that 3 million babies and mothers per year could be saved with high quality of care around this period, and also the care for small and sick babies. A busy slide for those of you who don't know NEST, and I'm going to break it down into 3 subsequent slides so you at least know a bit about it. But NEST stands for Newborn Essential Solutions and Technologies, and it's an alliance, really important to remember that, of 23 organizations, 18 of them in Africa, and it's really meant to tackle the SDG 3.2, which is the preventable newborn deaths. They're in 5 countries, and by about the early 2026, we'll have 1 million admissions on our data system. So let me break that down into 3 pillars. The first pillar is the bundle of technologies. We are at the BRC, where technology is foremost. We wanted to create affordable, robust, and durable equipments for low and middle income settings. This was to answer the WHO ENAP target, which said that all secondary level hospitals in Africa should at least have the equipment, which included CPAP, to treat level 2 babies. And of all this, they eventually looked at 6 categories, and out of that, 16 target product profiles was addressing the gaps. These were published, and it guided the procurement and became our NEST bundle. For Vigor, we also made sure that there was an 8-step NEST qualification process. And importantly, you can see there it was tested for our environment because of heat, humidity, dust, and that ever-present power outages that happens in Africa, unfortunately. It's ongoing, and so the performance monitoring of the devices within the bundle, we get some feedback, and we're still improving and refining these equipments. The second one is the education ecosystem, and you've just heard Dr. Josephat next to me talking about training and mentorship. It's not everything, and it's what we're familiar with when we go into new settings. Train and mentor them, but it's not everything. And specifically, when NEST came about, the change we made was what you see in blue. Not only was it a team of nurses and clinicians, but really multidisciplinary. And the game changer for us was actually to include the biomedical engineers and technicians, both in pre-service training, in-service training. You can see the triangle shows you the components of the training. Then the education system also developed many job aids for the equipments, video scenarios, and PowerPoints on open access materials so that end users could have it available. There was mentorship that you mentioned, but in addition, another game changer was to ensure that there was quality improvement processes, training and coaches. And importantly, cherry on top was to ensure that the BMETs and the clinical health workers were actually singing from the same hymn book. The toolkit, just to give you an idea from a material point of view, was also open access resource, including the readings, tools, and learnings. And by the end of this year, we way on more than 170 countries who've downloaded, and almost now on 1 million unique users to date. So this is all available. And then the last pillar, which is really the important one, and it focuses on data. But not only data, data systems, data quality, and data analysis. And I put an asterisk there because it's really important to remember that data is everything, right? Data is power. We know that as clinicians, as researchers. And NEST's guiding principle was really to ensure that we avoid parallel systems at the point of data entry. Really important to remember that. So what did it involve? It involved for the first time to actually create a limited neonatal inpatient data set, co-designed with governments. There was always a plan to ensure that this would be transitioned into the DHIS aggregated systems. Very important to make sure we look at quality, and started off with 55 neonatal variables, and I think is now at about 60 or 63. And then to add to that, Nested was developed, which was the implementation tracker, a facility-based tool used by the end user, the doctors and nurses in the hospital, and covering both quality and coverage indicators. So now we had the tools available for people in hospitals in Africa to actually have data-driven solutions, what we like to call data for action. We made it easier by creating fast plots, going really fast, and abacus plots. And then when we asked the end users in qualitative work with an implementation researcher, what were the examples of low-cost do-now actions? And you won't be surprised, a general enabler was actually to ensure, I think you spoke about huddles. This was particularly data huddles, using the QI run chart so people would actually use the tools that they were taught. And as I've said, from a data point of view, we will have the largest amount now of about 1 million newborns on our database by the early 2026. So what does all that mean and what has it done? Can we see any results? We've had a few interim reports, and the last one was in June 2025. And remember, we were targeting 4 high-impact interventions, and I've graded them there according to the highest impact CPAP and the lowest 4. Also remembering that this had to be done with quality. And we are tracking, just as remembering, in-facility neonatal mortality rate. And by June 2025, it was at 12%. The estimates was that the rate of reduction was 1% per month, and we're on track for our target of 18% impact by the end of December 2025. Right, so that was a bit about NEST. But what about the paradigm? How do we shift the paradigm? So these are the early learnings that we're seeing, both as a group, as a program, as an alliance, and also from my perspective. We can see that shift in paradigm by focusing on people. And when we say people here, we also include parents. Because I don't know if you'll agree, but the workforce trajectory in Africa is really changing. We're now getting more people on board for clinical things. It's multidisciplinary. And for us in NEST, it was definitely the game changer of including the biomedical engineers and technicians. There's a growing expertise, as you've heard, not only in cancer, but also in pediatrics. And the University of Cape Town, since 2008, has gone out to train the African Pediatric Fellowship Program, more than 100 subspecialists and specialists, and neonatologists all over. And so it's good to meet all those fellow trainees in countries leading. Of course, our crowning glory really is Dr. Queen Dube. She's the leader now, and she's the WHO Newborn Health Program lead. But it's not only at the global level. NEST also cherishes and fosters leadership at facility level, like Sister Maria, who's got 30 years experience in neonatology, but hasn't allowed me to share a photograph, so I'll share that in a while. And then NEST also has commitment to developing people by having design studios. We know that RICE has postgrad fellows from Africa, and the parent linkages that we pride ourselves on include parent groups providing input for qualitative work. And just recently, one of the moms, who was a mom of a preterm, actually won the first essay for a partnership. So what partnership is that? It's also important for us to actually be focusing on partnerships. And one of the most recent ones has been since April 2025, where under a grant with London School, the MRC grant, we actually brought together the African Neonatal Association, which is an association established in September 2024 for neonatologists within Africa. And we've collaborated as NEST 60 with them to grow the next generation of researchers, because that's really important. And these researchers come from all walks in the clinical sphere, statisticians, biomedicals, and of course, the doctors and nurses. We've got work streams for our high interventions, and we're looking forward to seeing a lot of research coming out of that. So there is a lot of research already published, because without that, it's all just talk. So in the BMC series in 2023, these are most of the ones that you can see in green. They're also being published by BMEDs themselves, by postgrad students using data for their MPhils and MEDs. And in our Alliance meeting, we now have a session called Share the Science, which was started last year with about 50 presentations, and this year, we're close to 100. So there's really a need for people to also share the data that they see. Importantly, I want to remind you that if you look, most of these papers acknowledge the people within country who are helping, and they're part of the authors' co-authorship, which I think is really important. And the ones I've highlighted, I want to particularly look at the one that says understanding health data falsification. Facilities and people within Africa are now looking at their own problems, reporting on them, and that's a start for change, and that's really, really encouraging. So I think you've mentioned, Joseph, about trust and teams. So we changed the paradigm by introducing trust, teams, and sufficient time for transition. So all the T's. Trust in building relationships within leadership and teams and between program and country leads. And the picture below is the first and only neonatologist from Malawi, Professor Nao Kawaza, who was actually instrumental in rolling out Pumani, which started here as the bubble CPAP a few years before NEST, actually. So that's very encouraging, and that's a relationship that is built and grown over time. The teams, strong leadership creates strong teams. We must never forget that we must integrate these models. We must have multidisciplinary teams available over and above the usual healthcare workers. And I think for the quality of care that we all wish to have, we must make sure that it's everybody's business, and that's when you have a team. It's everybody's business actually to improve quality. And so for an example, in your IPC, in your infection and prevention and control, don't forget the people that are not clinicians, but who also have a role to play in IPC. And I've mentioned the toolkit before, and that toolkit actually works very well, but they're also the team, and they actually reside at the London School of Health and Tropical Medicine. The last one I want to talk about, and this is, I don't know if anybody knows, but this is actually a change in, or a paradigm shift in how we deal with palliative care, and that palliative care now starts at the beginning of care. And so it's important for us to remember that the time to transition and handover must happen from inception. It must be planned and it must be funded. Without money, it's not going to happen. And it does take time. It doesn't happen overnight. You've seen in the global sphere things happen in decades, not tomorrow. And sometimes we're quite hasty. And so as NEST, we've already started in what we call the SSTF, which is a Scale and Sustainability Task Force. And remember, all things being equal, we've got 3 years to the end of phase 2. The last thing I want to talk about is providing the paradigm shift by providing support and sharing, and then those 2 words of scale and sustainability and how those interact. Support, you can see we pride ourselves that we only go into countries by talking to governments. I've mentioned the growth of the generation of researchers to come. From a financial point of view, the aim is always to ensure that there's an investment case, and we're building investment cases for all 5 countries that we're in at the moment. And Tanzania is a good example that's already happened. Advocacy, really important at all levels. And another highlight really of NEST is to ensure that we also support spin-offs. So we have an NGO called Hatch Technologies based in Nairobi, Kenya, and they now supply, support and maintain the essential medical equipment, and they're working at a profit. The last S is for sharing. And this is really exciting because we see a lot happening in countries, and we have a lot of cross-learnings. We have countries joining each other on implementation calls. And I think the need is really there because the courses we've created just in the last month when we launched had 8,000 CPAP online people. And that was only 2 weeks ago. And half of those were actually from Ethiopia. And also the need for QI, change and quality with QI. The QI online course already has 5 cohorts of 150 learners. So I hope I've showed you that what we're doing in NEST is actually building system. It's a system-based approach. It's not new, but we're doing it step by step. And at the heart of all of this is people. What you see here is the WHO building blocks, and we've added a couple more to the 8 that existed. But it's really allowing end users to catalyze locally owned evidence-based change. And in this way, we hope that NEST is actually really transforming health systems. So you might ask, is this working? Well, there are small changes that we're seeing. They're not seismic shifts, but they're small shifts, and they're important because they're showing that there's a new way to do things. At facility level, we now have morning huddles, which starts off with data, and people are looking at data on data dashboards. They're using their QI to look at coverage of care with quality. And I don't know if anyone has ever seen these equipment graveyards, but they're something of the past, certainly in the NEST facilities. Young health clinicians are now starting maternal neonatal units, which is very exciting, and this is in Ethiopia. These are 5 nurses and doctors in Ethiopia who've started the MICU. And from a global perspective, people are coming to Africa to actually have their conferences. This is the first Council of International Neonatal Nursing, or COIN, which was held in Lusaka in Zambia this year, and also the inaugural conference in Kigali for the ANA. So we're seeing those shifts, and the lessons we've learned, I see there's time, is, and this is really true, and I hope this resonates with you, in order for us to strengthen the health system, we must have people at its center. Supporting the handover process is important for all those reasons there. You can't start something if you don't know where the end is and who you're going to hand it over to, because funding is not infinite. And sadly, while we'd like to think there are quick fixes, technology is only part of the answer. Those drop and go shipments of equipment doesn't really work. And you have to have your BMETs involved. And kindly, please remember that sustainability is a journey and it takes time and money. So you've got to start thinking about it from the beginning of the program. And without the voices and advocacy at all levels, not forgetting those of parents and communities, we won't be able to address what's actually required. Thank you very much.
Thank you so much for both of your presentations. I think that we all found them very inspirational, very informative, and we have lots of questions to learn more. I just want to start off the Q&A with a question for each of you, and then I'll open it up to the audience. So the first question is for Dr. Lubega. We've seen how you've helped strengthen pediatric cancer care across Africa, and also we know that you've lived here for a long time in the US as well. And you know what happens in Africa too. So based on your experiences, what lessons do you think could improve how we expand access to children, or for children here in Texas and across the US? Is there anything that translates back over here?
Yeah, so it's now over 3 decades since a US president, Bill Clinton, declared that humans have sequenced the human genome, and within 10 years, everyone will know their genome and the risks associated with it, and to be everywhere. And I can tell you that even at Texas Children's Hospital, one of the creme de la creme of children's hospital in the US, even children with cancer who need their genome sequenced cannot get it sequenced routinely when they do it as research. So the issues of access to care, even when technologies are invented, are pervasive, and really, to me, they are the biggest problem of health systems everywhere in the world. And I think when you see this in a global setting, what brings you to recognize is you cannot walk away from it, and now it has become a science, right? It's a science of implementation research, where you really try to understand the social psychology, the health costs, the systems, the politics behind why these interventions don't get into people. It's the science of discovery itself, right? Sometimes the problem is with the discovery that, for example, genomic sequencing for a long time just costs too much that doesn't matter who you are. Even in America, you can't afford it. So to me, the key lesson we've learned in doing this kind of work abroad is actually you really become good at this science, right? Because the disparities are so more glaring in your face, but there's a lot to learn, especially in the US, where research that is less oriented towards a commercial patentable product is less funded, right? There's the drive, the commercial benefit from discovery. There's not a lot of motivation to get things that are already discovered into people. So I would say that to me is the key lesson we've learned is really there's a lot of need for things like health cost analysis research, implementation science, disparities research. Unfortunately, there is now a sense that all these things are politically driven, right? So one of the words right now, if you write an NIH grant, you don't want to include is the word disparities, because there is a system that will kick that grant out of the NIH system, but it's critical. It's very important.
Absolutely. Thank you so much for that response. Would you like to add on to that, Dr. Rhoda, or I have another question for you. Let me get to the question. So, Dr. Rhoda, I loved what you said about how that technology isn't enough and you need to focus on people. And you've emphasized the importance of collaboration with in-country partners. How do programs like NEST 360 ensure that local clinicians, professionals, that they are truly equally valued as leaders in this work?
So I think as part of my presentation, I mentioned that NEST 360, as part of its ethos, actually starts with governments. So I think that's the highest you can actually get in country, is the buy-in from the highest level. And from then, it actually cascades into who presents as the country leads, because those are sanctioned by the government, not chosen by a program, which unfortunately we have seen. And also adds then to sustainability, because you don't know what the modus is for those chosen people. But if the government itself, who we interact with, provide the leaders, already there's an element of buy-in at the highest level. And from a growth, where do we find leaders? Leaders are actually developed within universities. And African universities are multiple. We've both trained at each of them. Good quality universities, and they are part of the leaders. Then there are organizations within country, which we also have to partner with. In fact, we're lucky now in Africa that we've actually got an organization that's binding all the neonatal nurses and doctors. It's new, it's a young partnership, but these are all young, sub 40-year-olds who want to see the change. They want to see the difference. And there's that positivity. Because if you're not at the table, you can't be part of the solution. And when decisions are made in corridors and corners without those people at the table, that's when problems arise and sustainability becomes a problem. And NEST prides itself, and I hope I've shown that, at all levels to make sure that we've got the right people at the table to make those decisions, and to hope that those will be lasting decisions for the country.
Wonderful. Thank you so much for sharing that. I would like to open up the Q&A now. So if you have questions, please line up at the mics. They're in the back over there. Okay, we have one coming.
Thank you,
From here.
Drs. Lobega and Rhoda, for your presentations. My question is, have you encountered any tangible example of problems that you had due to political landscapes? And if so, how did you navigate them? Thanks.
Yeah, tough one, because politics is always there. And in fact, in preparing this talk, there were a few slides on politics. And I realized very quickly that the political scene can change. And I think that's why the focus should be on the people within facilities, the country leaders who are the doers. Because I worked as the newborn advisor for my country for 2 years, and for almost a decade, I was the chair of the ministerial committee. And you very soon realize that the political situation can change, but if it's embedded within your system and your system is strengthened, it doesn't matter who's in power, that needs to be there, and that will continue. If things are not embedded from the beginning, and you were giving an example of continuity, if there's no policy to make sure that there's money and funding, it's never going to come from the government. They're always going to look for things outside. And so I think that's really important. The political systems in Africa, as you know, there are wars within one of our nest countries. It was very difficult. It's very difficult to work when these things happen, but you've got to navigate it in a way that doesn't put the program at risk, because you know the politics might change, as you yourself know in your country, in the USA. And so that's what we do. We work with the people. We make sure that what we're doing is embedded within the systems, and that it's not affected by whatever political party is in power. Because that is a recipe for disaster. Because it shifts very quickly.
Yeah, I would totally agree with her, really, that probably the most common political challenge. I mean, if you don't have political buy-in, the work you're doing doesn't start. But the work having started, the most common challenge is Minister of Health changes, Permanent Secretary changes, and all of a sudden the next person doesn't want to know. And unfortunately, it takes time to get things really embedded in these systems into policy, which is the best way really to protect work from that. But that's a common problem you have to work with, and you hope that regardless of the political leanings of the leader, some of this work remains valuable, but that's a common challenge you really keep working on.
Great. I think we have another question.
Thank you both for the presentation. It's been very insightful. My name is Patience Chimboza, and I'm a Rice graduate student here. And I know there's been a lot of talk about politics, but my question is in two parts. The first one was, as the next generation of policymakers, what are some areas that you believe need focus as challenges that you have experienced in current implementation?
I think, to me, I would say the biggest problem right now that relates to politics in these countries is the issue of financing for healthcare. There's been, as you know, so much dependence on foreign aid. Everyone knew that it wouldn't last forever, and it wasn't really the most appropriate way. And I can tell you honestly, quietly, many African governments, leaders are happy with these shifts because they feel, programs like PEPFAR, yes, were benefiting the population, but there were also political tools that were making them do things in ways they don't want to do them. So now there's this big movement towards self-sufficiency and local funding, and everyone's talking about it. But the reality is they don't have the resources to do it. And I think there are so many things people are thinking about. How do you move philanthropy to blended funding, for example, social impact bonds and all things like that to get these systems be self-sufficient in terms of health financing. But I think that's really the biggest challenge out there, and we don't have that solution other than trying to design systems and technologies that lower the cost, but we cannot come up with the monies that are required to sustain this kind of work.
Going to be a bit controversial. If there's one thing that Africa is not, is poor. We've got lots of resources, but because of politics, they're just not diverted to the right areas like health, for example. It's the future of our continent, and yet. So I would agree with you, it is finance. But I think countries like Tanzania have shown, and yes, it's a particular president, but with the right support and seeing the changes that have happened, and in this example, the lives that have been saved with programs like NEST, there's an impetus for people to make a difference. And when you get critical mass thinking that way, and this might be long term, but remember, we're not talking about days and months here, we are talking about years. Planting that seed, building upon that, saving one baby at a time, showing what can be done. There's so much pride and dignity now that's coming back to countries that I'm also hoping that the bottom-up approach, as they've done in Brazil, where they educated people on what your rights are, what your political rights are, what your health rights are, what you can demand. Because our population is silent at the moment, and that's the problem. But if we educate, motivate, we must start seeing those shifts happening. And as I said, of the 5 countries, we're busy with our 4th investment case now, and that's positive, that the governments are actually giving of the country, and by the way, it's our money, for health. That's very positive.
Thank you so much. I know I'm monopolizing, but the last bit of my question was, as a Zimbabwean, I know that privatization of healthcare has become a bit widespread. So I wanted to ask you, Dr. Roda, what are some barriers that you've seen in implementing this newborn care initiatives that have been affected by the privatization of healthcare?
Unfortunately, health is a business, isn't it? And that is the problem. So in our country, we're trying to go towards, in our country, we spend 8 times more money in private than what we do in public, and yet the majority of patients are actually in public facilities. And I've worked for 30 years in a public facility, never stepped foot into a private facility. And unfortunately, for as long as health is going to be a business, perhaps the only answer is to see how we can leverage off the private. Because remember, all the doctors that are trained, they all come from the public government sector. The government subsidizes. When I was training, 60% of my fees was subsidized by the very government that I decided not to go and work at. So there has to be a trade-off. It's not easy. We've had white papers, blue papers, pink papers for our universal health, and it's very costly. But finding a way to leverage off the private to assist. So for example, if your hospitals are, the public hospitals are full for newborns, can patients get care with a set number of beds within the private sector? These are all solutions that we must start thinking about, because it will just get worse. And you're right, the Gini coefficient in South Africa is the worst in the world, and we're seeing what that does. Despite having all the riches, there are still people who can't access care, rural, or just not able to. And that's a huge problem. Not easily solved, but we're working towards some solutions in universal healthcare.
Thank you so much.
I wanted to take one last question, and then I think we'll break, but let's take this one over here.
Thank you. Sarah Berkelhammer from University of Washington, and I just applaud and am so impressed by the work that you guys have been doing. For Dr. Rhoda, I am still, as you have made such a passionate plea for, the data is so critical to any type of progress that is made in resource-limited settings. And there's this ever difficult tension between having overburdened staff and the ability to document and having them in that system. And do you have insight or advice in how you can make that move from financed or supported research environments that are going to be collecting that data to the local ownership, where we're really empowering providers in terms of their understanding of where this data is so critical to their own progress, and how we can build systems that will help them to collect that data as well outside of a research setting. So it's somewhat towards the same question around sustainability, but in our vision of improving healthcare in the low resource setting, making that data collection part of the agenda as well. So your insight into that as your programs have been amazing in collecting that.
So I'll give you an example of my own country. We have far too many indicators. So one of the things that is really required is a finite set, so a limited amount of data, because as you rightfully said, you need people to also enter that data, and those are usually also sometimes the same people who are providing care. And so what falls by the wayside is, I'll rather do the care, but I'll do the numbers later. So limited data sets that can actually give us, and I think India is a good example. They've had a limited data set for a few years now, and of course they're a massive population, and that's driving everything they do. Their research is now driven by their own data that they don't have to compare elsewhere. They've got the data within country, and that's what we're moving towards. Yes, we're only in 5 countries, but I think I've told you that the idea is always to make sure that those data sets are actually being incorporated into the DHIS system. And also, data is power, but also it needs to be demystified, because sometimes data, and unfortunately I've also come across within my own country, people who own data have the power and don't share. But if you can demystify the data, which is why I very quickly showed you the fast plots, it was color-coded, anybody could read it, you don't have to be a statistician. That's really important, it makes it easy. The abacus plot, how big is your unit? Is it red or pink? If it's red, it's bad. If it's pink, it's better than red. And if it's green, you've reduced your mortality. Making it more tangible for people to actually use the data is also really important. And I think people at local level, sisters, nurses, they're seeing the benefit of it.